First slide here again is taken from the European guidelines and just emphasizes that we want to use risk factors and symptom presentation plus EKG plus troponin elevations to kind of diagnose and categorize our patients. And mainly what we're looking for is trying to identify the patients with significant CAD and ongoing ischemia for our cath and our antiplatelet and our anticoagulant therapies. Uh, we want to start thinking, and you all realize there are lots of other causes of raised troponins besides ischemia and CAD. And this is a 2019 algorithm in a type 2 MI paper telling us how we should think about this. And there are basically four important diagnoses or categories we should be placing patients in with elevated troponin. And those are the four boxes along the right there. Chronic injury, acute non-ischemic injury, and then our ischemic presentations with either the type 1 or the type 2 MI criteria. And keep those categories in mind. And what the guidelines and things are really emphasizing and what we want to do clinically is we really want to ever avoid the term troponin leak. Okay, so troponin leak is really meaningless and doesn't connotate any etiology, gives a false impression, frankly, that the patients have a good prognosis when in fact the worst prognosis you can have is to not have an MI and have a troponin elevation in most cases. We don't want to attribute troponin to demand ischemia in most cases. Demand ischemia is trying to connotate and actually explains that the patient likely has significant CAD, but has ischemia based on anemia, hypertension, uncontrolled hypertension, low blood pressure, some other factor here. But remember, demand ischemia and that specific type 2 MI, your patient still requires some finding or objective evidence of ischemia. And that can't just be atypical chest pain or shortness of breath. They've got to actually have angiographic cath imaging, definite EKG changes, along with a sufficient rise and a fall of a troponin. And the other take home here is that we want to try to give a specific cause and mechanism then for each and every troponin elevation in that chronic injury, that acute injury, and that type 2 MI category, because we don't believe those are the cases provoked by severe CAD and plaque rupture. Now, the new troponin and biomarker tool we're using are the high sensitivity troponins. There are high sensitivity troponin T and high sensitivity troponin I assays out there. Ever since 2 years ago when we started reporting the nanograms per liter, we actually switched to a high sensitivity troponin assay, but we have not been reporting the low values prior to this year, July. And that's the new thing that we're going to talk about and conclude with what the implications of that. Keep in mind that any troponin, but particularly high sensitivity troponin, measures damage to the myocardium both from ischemia and non-ischemia. So again, an elevated troponin does not mean acute MI. Troponin obviously goes up with cardioversions, ablations, cardiac surgery, sepsis, heart failure, renal failure. All those things that, again, we don't want to attribute that to CAD, demand ischemia. Don't want to be prescribing those patients aspirin, Plavix, and those type of things in most settings. The definition of a high sensitivity troponin is that we should be able to measure a level in more than 50% of healthy people. So the last 2 years we've been reporting less than 18 nanograms per liter and not trying to do that. But in fact, the majority of patients have a measurable level of troponin below that 18 cutoff that we can report and that now we are reporting in the Henry Ford Epic system. Okay. It is a new advance in that the testing, the high sensitivity, is much more accurate at these low troponin concentrations. So you can measure low levels and you can measure small changes much more accurately than we could before with the prior assays. And what that means is we believe you can use values now in the emergency room setting at baseline in 1 hour to make your diagnosis and your decision making. And what we're recommending on the inpatient side, where we don't have good data for 1 hour protocols, is that we check troponin at baseline and 3 hours now after a patient has acute symptoms. or any type of chest pain reported here. Okay. Now, important things in using the high sensitivity troponins are that if you have a very low troponin, high sensitivity troponin, right at the bottom level of detection or level of detection for most of these tests, you can in 1 hour or even sometimes at baseline pretty much rule out myocardial infarction within that first hour. And I'm going to show some data for that coming up here. And the other thing is that you can use that 0 in that 1 hour and maybe avoid cardiac testing, observation, unit triage, admission in approximately 40 or 50% of those patients. And we'll go over that data kind of coming up. At Henry Ford, we're using a troponin I assay made by Beckman. That 99th percentile of the normal population, or what we call our threshold value, minimum criteria to be an acute MI, is 18 nanograms per liter. And that's where that 18 nanogram per liter reporting kind of was included in the past and the present EPIC reports for the troponin results. Now, don't think that means a troponin over 18 equals MI. In fact, much more than 50% of patients with troponins greater than 18 do not have type 1 or type 2 MIs. Okay, it is mostly these myocardial injuries that we, again, do not want to treat with cath-CAD testing and CAD meds, frankly, here. You need probably about a 5 times the upper limit of normal. So I'm going to show you our algorithm later, which uses a value of 100, frankly, before you really get about a 50% chance that the patient actually has ischemia and acute MI to be the cause of it. And that most people, what we're seeing and what's been reported in the literature here is even though we're going to use very, very small changes over the first hour for our triage and our decision making, most acute MIs have very significant rises within that 1 hour, well over 50 nanograms per liter, or maybe 20% relative changes to really be an ischemic change or a meaningful change from a chronic injury type of pattern. So what that means with the new troponins is you should be diagnosing and you will be seeing lots more of these acute and chronic non-ischemic myocardial injuries, okay? And for the patients with true CAD, what we're seeing is you'll see a lot more of type 2 MIs, small number increase in type 1 MIs, and pretty much unstable angina will be kind of nowhere. So most of the results reporting on the high sensitivity troponins shows that the patients classified as unstable angina now is really a low number with the troponin testing compared to those given the definite MI diagnosis. Okay, now how we use the troponin, the high sensitivity troponins, particularly in the ER setting, is spelled out here in the 2016 European Heart Journal biomarker recommendations. The United States guidelines for non-ST elevation acute TMA have frankly never been updated from 2015 to specifically give us recommendations on high sensitivity troponin. The US guidelines still say we should be checking it 4 to 8 hours afterwards as our second value. But what this slide is showing you is that ER doctors are recommended to kind of categorize the patient based on the 0 and the 1 hour troponin into a very low risk rule out group, a higher risk rule in group, and then kind of an intermediate observation further testing group. And what you see here with the different cutoffs for the different troponin T and troponin I assays here is if you take just a very low level of detection for these assays in nanograms per liter, and you recheck it in an hour with these type of very small increases in that 1 hour from the baseline value, you can identify a group of patients here that have very low likelihood of acute coronary syndrome or MI and likely do not need any further testing or evaluation. Okay. In the intermediate or the higher groups, we're using much higher cutoffs, 3 or 4, 5 times again the cutoff for the AMI, 20, 50 times the level of detection for these assays here to predict which of these patients more likely will have acute MI. And this is important because when you follow patients out for even a full year, and we use that initial 1 hour difference in their high sensitivity troponins using both the troponin T or the troponin I, you can see that at a year out, that very, very low risk group has incident rates of death well under 1% compared to 7 and 10 or 5 or 8% of the patients who go on to have cardiovascular or total mortality in the first year. Okay. Now, most of the studies that have looked at these high sensitivity troponins basically just take lab samples from, a cohort of patients in the emergency department, and then you pay a lab company to use their assay, you run their assay, we know their adjudicated outcomes and things like that, and then we analyze and see how good the assay is. So this is data here from our own emergency department and observation unit 2016 and 17. And what you see is Dr. Nowick's JACC publication here using a troponin T assay in 500 patients when we applied this. And again, these were not results that you or I or the ED doctors or anything saw. We're just later running it with the new high sensitivity troponin T assay. We're using a cutoff here of 12 and a change in an hour of less than 3 for the patients here. You can see in this low risk group here, we did not miss a single acute MI during the index hospital stay. And overall, we had a total of 2 MACE events with 1 death and 1 AMI in the patients who would have been triaged to no further testing. Now, conventionally in the ER population, what we want to do is we want to make sure that this stays well under 1% so that there's no threat of a missed AMI or serious event in that 1% range here. So what you see again is 514 here. This was about 48%, I believe, or so of the total population here into this very, very low risk group here. And then our intermediate group had about a 10% rate of MI. Our higher risk group, which was only 9% of the patients, had a 56% MI rate with higher proportions here. So again, at Henry Ford, this 3 risk group exclude with very, very low values in the first group looks like it's a effective and adequate way to triage and evaluate patients. Now, there's only one major publication thus far using the troponin I assay that we're using, and this is the Beckman troponin I assay, implementing it with the 0 and the 1 hour. And again, this is similar to the Henry Ford study I just showed you. This isn't real ER doctors or patients making decisions with the assay. This is just analyzing a group of 680 European patients afterwards using the assay. And again, what was used in this protocol was they used a cutoff value of less than 4 if the patient had symptoms for more than 3 hours, or if it was less than 3 hours, they had to have a 4 or a 5 reported value and a 1 hour change less than 4. So it didn't rise by more than the 4 nanograms per liter. And again, in this population, 60% of the patients were able to be placed in the low risk group initially versus 26 and 14%. And what you see here is you saw 1 MI total for the 0.2 missed, the 0.2 non-STEMI rate here at 30 days. But again, well under the 1% false negative result here that you had missed cases. 15% MI rate here, 74% rate here, using again much higher cutoff value than the MI rate, but again all adjudicated and predicted here. So again, we've chosen an assay here at Henry Ford, unfortunately, that doesn't have robust multiple trials and things proving it works with pre-published and good cutoffs, but the data that is out there is fairly favorable, at least for ER decision makers, to be implementing and using with these low cutoffs. Okay, and that kind of brings us to the article we're discussing here today. So the highlights of this article are it was conducted between 2015 and 17, 2 academic hospitals 2,300 patients, and very importantly, this was actual patients and a prospective protocol. So this is not a bunch of ER patients and administrative data where you go back later and see what the troponin would have shown or done. This is an actual educate the doctors and providers, tell the ER doctors to follow the protocol, which is using the troponin T, 0 and 1 hour decision making and risk stratifications. The protocol did give the ER providers the ability, though, they could overrule the algorithm and individualize testing or triage whenever they saw fit. And frankly, that's probably the only and the correct ethical way to do any of these studies. And it wanted to determine whether you really could do a 0, 1 hour and make good, safe decisions in these patients. It's a very well conducted study, so you see effective 30-day medical record, telephone, death registry follow-up in 100% of patients. And this is just going over the paper kind of thing. There's no complicated methods or anything here. The paper doesn't really say what percentage of all ER patients were included, but the editorial suggests that probably between 1/2 and 3/4 of the patients at these two hospitals were actually included to get the numbers and the things that they wanted to use. Again, it's using a established high sensitivity troponin T assay that has an acute MI cutoff of 14 nanograms per liter and can report values all the way down to 3 nanograms per liter, which is actually the same range that our algorithm uses here. Again, the follow-up is very good. In terms of feasibility and was the study able to be performed, the answer was a strong yes. So in this patient population here, what you saw is they were over 94% of the time they were able to actually get the baseline and the appropriate 1 hour blood draw in these patients. The average, I believe, was 62 minutes instead of 60, which is neat here. They were able, the doctors in this real study were able to discharge 71% of the ED patients directly to home without using telemetry or observation unit. And what you saw also very, very impressively was in this lower risk or this rule out group, only 9% of patients overall got further cardiac enzymes and or non-invasive or cath testing in this patient population. So again, very, very efficient when you gave providers this algorithm to do it. Okay. And again, the highlights of this algorithm in the low risk, the intermediate, and the high, 62% of patients had the symptoms greater than 3 hours with a baseline less than 5. Patients who required with symptoms less than 3 hours or required a 1 hour here, they used a cutoff of 3 in this group. And you had 62% or so here versus 25 in the intermediate, 13 in the higher risk rule-in group. In the rule-out group here, what you can see is not a single myocardial infarction occurred during the index hospitalization. There were 2 additional MIs and 1 cardiovascular death within 30 days, generating you this overall adverse event rate of 0.2%. Well under the 1%, again, that you would be concerned about or worried here. Your MACE rates here were 5% and 67%, obviously mostly influenced by the proportion here that ruled in for MI, which was, in this study, over 50% likelihood within that small 295 patient group. Okay. Here's just kind of the highlights of the overall study. 3/5 of the patient able to be in that lowest risk group. These providers comfortable discharging 70% or so. Very, very low rate of in the hospital and even 30-day event rates here. Managing the patients without testing in over 90% of the cases here that we saw. And that leads us here then to the Henry Ford ER chest pain evaluation. here that you should be seeing or implementing prior to patients coming to H5 telemetry and the chest pain units here that we have. First thing you notice is it doesn't have the 3 boxes, it actually has 4 boxes in, and the reason for that is these 2 columns here combined are pretty much the equivalent of the lower risk group that we saw before in the published trials. And what you can see here is what Dr. McCord is given the slogan of less than 4 out the door. So if a patient has a troponin of less than 4, meaning 3 or undetectable on just that single value, okay, and their symptoms are less than 3 hours, we're no longer recommending any further biomarkers or testing. If their symptoms are less than 3 hours and they're less than 4, then they warrant probably another 1 hour testing, okay? Now if they have a very, very low value equal to 4, so less than 4 out the door, equals 4, 1 more. So by that we mean equals 4, they need to get a repeat 1 hour. And if the repeat 1 hour goes up by less than 4 or remains less than 7, they again comprise that low risk group that we're not recommending any additional testing. Now, consult team has told us that there probably are some of these already still being admitted to CDU and some of them still being recommended to have testing. But this really is the group where the high sensitivity has its most value for us, frankly, hopefully discouraging admission, observation, or any kind of further testing, okay? We jump over to the rule in or the highest risk group. Again, 18 is the cutoff for MI, but again, 18 is not that useful or important for triage or decision making. When you get values here closer to 100, or you get a change in that 1 hour more than 15, that's typical what we're seeing, that patients that rule in are adjudicated with an acute MI, okay? For triage and decision making, again, that what we're saying though is if you're out of this well above 5 range, if you're above 18 and have an incremental rate of greater than just a 15, again, you more likely than not may have an acute coronary syndrome. And frankly, these patients are recommended to be admitted directly to telemetry and not to the CDU, although the CDU is certainly reasonable for most of these patients here. And then the intermediate group, so kind of patients between the troponin of 100 and above 18 at some point here. What we're recommending is use your symptoms, use your heart score, which again is that combination of symptoms, EKG, risk factors, age, those type of things here. And again, if it's atypical symptoms and no CAD risk factors, funnel those patients back towards just like the lower risk group with no inpatient testing or evaluation needed. If it has typical symptoms, multiple CAD risk factors, or the HERE score greater or equal to 4, that's a reasonable group for CDU and further non-invasive testing for most of those patients here. Okay, so again, lower risk here, combination of the baseline and the 1 hour, very, very low difference. Telemetry, cards consult, CAD testing, likely cath in the higher group here. And then again, narrow group that should be getting stress testing, hopefully with this algorithm here that we're doing. Now, we are actually, as we implement this, we are actually collecting data, and we've been collecting. So Dr. McCord is kind of categorizing and collecting data on the next 12,000 or so patients managed in the ER using this implementation, using this protocol that's being spread to the different ER providers. And basically what he's investigating is, in that low risk group, is that really safe to discharge and not test them further? So he's going to collect data and look at 30-day death or MI, and we'll collect data on cost, lengths of stay. As Bright said, we actually went live with the study and the implementation together at the end of July this year. And over the next 4 months or so here, you can see each of the satellite and urgent care places that evaluate patients with acute chest pain or ischemia will implement their reporting on Epic, similar to what we have now here at Henry Ford. And they'll be asked to follow that protocol or algorithm that we just went over on the prior slide. Again, no disciplinary action or requirement. We always want people to do what we think is best. But again, this is what we're really encouraging them to think and categorize the patients. So again, new ability to rule people out quickly and frankly very, very safely. Good data, including the Journal Club article, that not just looking at labs post, but actually in the real world, real time, if we use this kind of decision making and algorithms, particularly for the lower risk patients, we can avoid a lot of testing admissions and hopefully get just as good as outcomes as they published here. So